I'm a medical oncologist as well. I work at Clatterbridge in Liverpool, and my specialist interest really is in uveal melanoma, which we're going to go through today. On this diagram here of the eye from Melanoma Focus, which looks lovely, apart from those little brown bits, which are the melanoma that have developed in the uveal tract. So that's in the pink around the eye. It includes the choroid, the most common source of uveal melanoma, but also in the ciliary body and the iris. So I thought I'd start with why do we need uveal melanoma specific guidelines? And when you look under the microscope, uveal melanoma and skin melanoma look very similar. We do a lot of tests that are indistinguishable between the two. And so that has kind of led to them being lumped together a lot. And obviously I'm here at Melanoma Conference. But although they originate from the same part of the embryo, that's the neural crest, and then they migrate from there into the parts of the body where they have their function, they then diversify. So they look quite different in terms of the melanocytes that you would see within the uveal tract versus the ones in the skin. And presumably the environment there modulates how they behave, as well as what sort of signaling is involved in determining how they function end up in their niche. And then from there also, they're exposed to different sources that cause mutations and changes in the DNA, and the mutations that occur are very different. So that really means that these end up two different diseases. And when we look here at a contrast between the two different types of melanoma, you can see very big, differences, as I said. So first of all, the incidence is much lower. So it's less than 5% of all melanoma is uveal melanoma. We don't see a UV signature. In other words, it isn't the UV light that is causing these cancers to occur. We still don't know why uveal melanoma develops. The mutations, as I mentioned before, are different. GNAQ, GNA11 for uveal melanoma versus BRAF, NRAS, and NF1 for cutaneous melanoma as well as others. There's a much lower genetic mutational burden, so that's the number of mutations of the genome between the two. So if you plot them, uveal melanoma is at the bottom in terms of cancers and amount of mutations, and cutaneous melanoma is up here. So again, very different. They spread differently. So uveal melanoma almost always goes to the liver first. It spreads through the blood, whereas with cutaneous melanoma, it goes, unfortunately, other places, including liver, bones, and brain, but often the skin as well. And I think historically, the need to divide them was less because both uveal melanoma and cutaneous melanoma responded very poorly to drugs. And that sort of changed when, after chemotherapy, we started getting the immunotherapy agents, which have revolutionized cutaneous melanoma, and similarly, BRAF and MEK inhibitors. But that hasn't happened with uveal melanoma. I think that's on the cusp now of changing. So the uveal melanoma guidelines date back to 2015, where they were commissioned by Melanoma Focus and published using a rigorous NICE approved methodology. And then they were updated over 2020 to 2022, specifically looking at the treatment of metastatic disease, as well as some of the other aspects. But we had initially left out surveillance, that is the regular follow-up after the primary disease to identify early metastases. And then this was, so another group was set up and has done this, and we've now got the sort of combined guidelines, which are very comprehensive. And these were developed by a big group of people over many months of meetings on Teams and during COVID, et cetera, trying to get the best evidence and to use the rigorous approach to where there's lack of evidence to try and find a consensus. And this was the second group. So what's new? Quite a lot of it has been revised, not necessarily to a great degree, but we've listed all of these down here. And I obviously don't have time to go through everything in detail. I'll just touch on a few of these aspects today. And there is also a link on there for the guidelines for patients and carers on the Melanoma Focus website. So one of the things that is particularly the case with uveal melanoma, because it's a rare disease which many individual consultants, for example, may never see, or one a year or something very rare. It's really important that we try and get adequate information, good information to patients, and try and drive that to excellence. And so a lot of what this is around trying to make sure we can get the information in a individualized manner and to drive that excellence. I'm not going to read through each of these in turn, but they are on the website as well. And really, we also felt that it's very key to have a named key worker and ideally a clinical nurse specialist. Scans are often an issue with it being a lot of surveillance, so trying to make sure that these are given as early as possible. And then to try and then also improve access and also information as to that access, because that varies across the country. Then turning to liver surveillance. So in the 2015 guidance, the 2015 guidance was that liver-directed metastatic screening should be performed for high-risk patients 6 monthly for life. But the guideline group wasn't able to agree on a definition of high risk. And this is difficult because it's a continuum. There was an acknowledgement that there was no evidence of impact from screening, but it was felt that early detection of these metastases could lead to more access to treatment, including in around 10 to 15% of patients, liver resection, which can lead to long-term control of the disease, but not cure. So this is the updated, this is what happened with the updated guidance. So unfortunately, we still don't have any really strong evidence, but we do, of benefit of surveillance, but we do know that there's now improved survival with Tebentafusp. We know there's improved progression-free survival with chemosaturation, which I'll come to, and these also appear more effective with low-volume metastatic disease. So as we're gaining treatment options, therefore identifying early disease makes sense. The consensus was that not all patients should be scanned because often the risk is very low and it is over many years. But there was still some, very difficult to agree on what the category for high risk, but the decision was more around defining what was lower risk. It was also felt that biopsy of the primary tumor remains, although contentious, is very valuable in terms of providing prognostic information. And also that from a lot of guidance and the looking at where the recurrence occurs, 10 years is probably a good cutoff, because beyond that, the risk of a recurrence becomes much lower. So the guidelines currently are that all patients should be offered a discussion around surveillance, if possible, to use a multi-parametric model. So this is using as much information as possible to understand the risk and to guide the discussions around this. We've got a tool called LUMPO3, which is available online, based from Liverpool, but uses all these different factors to try and identify risk. And then where there isn't genetic analysis, because sometimes you don't have a biopsy, to look at both scenarios, what it would be like if there had been a chromosome 3 loss or not. And patients with a less than 10% metastatic risk at 10 years should not be offered routine surveillance. We know now, we know that ultrasound and MRI have differences in sensitivities, but they're probably equally useful in terms of decision-making for surveillance. Liver function tests don't really have a role in surveillance, and the decision is for scanning should be for 10 years with 6 monthly for the first 5 years, then annually to 10. And then if honorary surveillance, to discuss any changes that the guidelines may be driving. So that's really unbelievably, that's probably the most contentious topic in the whole of uveal melanoma. Has always been about which surveillance to use, how often to use it. So it is really important to have guidelines, and we can try and benchmark against that. But this is where I'm mostly involved in, which is in the treatment of metastatic disease. And if we go back, or not very far, the only option was chemotherapy, which has never shown a survival benefit, which has hardly any likelihood of shrinkage of the tumor, and even where shrinkage occurs, the likelihood of the control is very short. And then the immune checkpoint inhibitors came along, and they were licensed in melanoma. So we've been using them in uveal melanoma. And that, there is some benefit, but if it had been on the basis of uveal melanoma trials alone, it wouldn't have been funded or licensed in uveal melanoma because the benefits are low. We all know what the immune checkpoint inhibitors are in this room, and Sarah's already mentioned them. These are inhibitors that remove a negative signal and thus stimulate the immune recognition of the cancer. And the single agents include anti-PD-1, nivolumab, and pembrolizumab, as well as ipilimumab, which is anti-CTLA-4, slightly different mechanism of action, and of course the combination. If we look at responses in uveal melanoma, in the different small trials, these range from 1 in 10 to 1 in 20 patients gaining benefit from anti-PD-1, and even in some trials as low as 3%. So a very small likelihood of benefit, unfortunately. And the average life expectancy is on the anti-PD-1s has been in the 12 to 18 month range, which is unclear as to whether that's been changed by the immunotherapy or whether that is just similar to patients untreated, unfortunately. You all know a lot about the latter bit, so I won't say anything about that. CTLA-4, this is ipilimumab, has similar sort of efficacy from what we can see from trials so far, but has a higher likelihood of side effects. And combination ipilimumab and nivolumab has now been investigated in 2 single-arm prospective studies, as well as some retrospective analyses. These 2 main studies are a Spanish study which had 52 patients, which was first line, so it was homogeneous, which had an 11.5% response rate and an average life expectancy of 12.7 months, which, as I say, which you can see is on the lower range of the figure I talked about previously, and so similar probably to anti-PD-1 alone. And I think that's probably a more representative trial than the US study of 35 patients, because that included second line as well and was less homogeneous. That had a higher response rate. Interestingly, when they did a combined analysis, those patients who had uveal melanoma that spread more outside of the liver did better on combination immunotherapy than those who had liver-only disease. And I think that's partly about the liver environment, which sort of suppresses the immune system. The problem with combination ipilimumab and nivolumab is also the side effects, as we all know, which are can be very considerable and can be very long-lived and can impact on quality of life. So even though the response rate is a little bit high and potentially a little bit more benefit, it's really a question about whether that's worth it in terms of the consequences on side effects. We have had a really important change in uveal melanoma recently with Tebentafusp. This is a really neat molecule that's been devised specifically for melanoma and started off in both skin melanoma and uveal melanoma, and for that matter is going back to skin melanoma again after some years. But what it is instead of trying to remove that negative signal, which the checkpoint inhibitors do, this tries and uses any T cell that's floating about in your body. So you could have an influenza one, any viral, COVID, whatever. You've got a T cell that's kind of been stimulated against that. But then we use an anti-CD3 part to this, and that binds onto the T cell. And then the other end recognizes a protein that is expressed in uveal melanoma called GP100, also in cutaneous melanoma. And so it brings that T cell into the tumor and then sticks the T cell onto the tumor and stimulates it to kind of degranulate, so produce poisons that kill the cancer cell. So it's really neat because instead of actually relying on the immune system recognizing the cancer, we're doing the recognition for it. The problem with this is that it relies on a specific HLA type. So only patients who've got HLA-A0201, which is somewhere between 40 and 50% of the population, can receive benefit from this trial. Hopefully, with time, we'll get similar molecules against other HLA types. But of course, it sounds like a cool molecule. The real thing is whether it helps patients. And in this large phase 3 study, we showed that the overall survival with Tebentafusp was 21.7 months compared to 16 months with control. So it's a 6-month improvement in survival, which is a real change. And there are some people who do seem to gain longer benefit as well. This remains under follow-up. And so it's the first trial to ever show a definitive improvement in overall survival in uveal melanoma, and hopefully is just the start of a lot more to come. The other thing is you can see was compared to commonly used alternatives, anti-PD-1 and anti-CTLA-4, with a control of 16 months there. Interestingly, response rates don't predict for benefit. So even if the disease grows initially, that doesn't necessarily mean there isn't benefit. And we've been looking into using circulating tumor DNA from the blood to work as a marker to identify those who respond. The downside is it's a weekly intravenous treatment, so people have to travel every week. And the initial side effects over the first month are quite intense, so with rash and what we call cytokine release syndrome, which can make blood pressure drop and nausea, etc. But importantly, those sort of go away after 3 or 4 doses, and after that, the treatment is very much more straightforward. And I would say overall the side effects are better than checkpoint inhibitors. It's not currently NICE approved, and this is something that is obviously really disappointing. They turned it down initially. It's then gone to appeal, which was positive, but then there's a whole nother process to go through. Hopefully, that will lead to it being available. Delcath is another treatment that has shown benefit in uveal melanoma recently. This is basically a filter system that allows you to pump very high doses of chemotherapy into the liver, because that's where the metastases usually are. Take the blood out again, take the chemotherapy out, and then put the blood back in. That way you can get much higher levels of chemotherapy in the liver that are strong enough to actually kill the cancer. It is complicated, as you can see here, with all the people involved with perfusionists and interventional radiologists and anesthesia, etc. But it does, it is definitely feasible in the NHS, and we've done it as well previously. So it's mostly it's really specific to patients who've got liver-only disease or liver-dominant, because it's not really treating the rest of the cancer. The treatment is every 6 to 8 weeks, depending on recovery. That would be nice, depending on recovery, and it involves often about a 72-hour hospital stay, although when set up, the stay is usually longer, and then when people get more experience can take it down. But it only involves 2 to 6 treatments to get benefit. Again, no current NHS access, and this is something under active discussion. So the main trial that I was mentioning is the FOCUS trial of chemosaturation. So I think it must be the treatment that has the most different names out there. So chemosaturation, percutaneous hepatic perfusion with melphalan, Delcath, and they've now called it Hepzato kit in the US as well. So all the same thing anyway. But this FOCUS trial had 91 patients treated with PHP or Delcath against 32 patients who were treated with best alternative care. And the confirmed response, out of those 91, there were 33 patients with confirmed response to treatment, that is a reduction of 30% or more, and 4 in the control arm. Importantly, the time to progression-free survival was much longer with PHP, 9 months versus 3 months. And there was also a hint of an improvement in survival, although I think mostly because of the numbers, this hasn't been statistically significant. So good things and bad on this slide. With the pending licensing and availability, the guidance is pending of licensing and availability to consider offering Tebentafusp to HLA-A*02:01 positive fit patients with metastatic disease. But obviously, we don't have that availability at the moment. The second one is to consider immune checkpoint inhibitors in the absence of a relevant clinical trial. And as I've said, unfortunately, immune checkpoint inhibitors benefit is really quite slim. And then for patients with liver-only or liver-predominant disease, we can consider local or local regional therapy. Now, that is mostly unfunded. So we remain in a situation where we've had advances, but these haven't yet made it into our clinical practice in the main. But there are a lot of exciting things on the horizon, some of which Sarah's already mentioned. So TEBI-MRD, for example, that's looking at circulating tumor DNA, so little fragments of DNA from cancer cells that are pumped out into the bloodstream that we can then identify and hopefully pick up the disease at a level that it is so early that we can't see it on scan. We've got 2 cohorts for that, one of which is in cutaneous melanoma and one is in uveal melanoma. And the idea is we pick it up early, treat it at that point, and eradicate it. There's also a more standard adjuvant trial, so after treatment of the eye, to give Tebentafusp. This is an ERTC study, which will be across multiple sites and hopefully starting in sort of Q3 this year. There's a commercial study of darovasertib, a PKC inhibitor, pre-surgery, aimed to reduce the size of the tumor and reduce the chances of needing enucleation, removal of the whole eye. There's also a new combination of drugs called darovasertib and crizotinib. They just roll off of the tongue, don't they? Which in the phase 1 has a really high response rate for this, an unheard of response rate, basically 46% confirmed partial response. And this is now going into phase 3 study, started internationally, hopefully start in the UK soon, and I'm sure will lead to another standard of care. This is being investigated, at least initially, in HLA-A*02:01 negative, so then hopefully we'll have an option at least in each of those. Chemosaturation has then also been looked at in combination with ipilimumab and nivolumab in the Chopin study in the Netherlands. And we've also got other agents that are just coming through. So one of the studies I've been quite intensely involved in is RP2, another oncolytic virus like RP1, injected into the liver lesions themselves. And we've seen really nice responses. So not only killing the cancer into which it's injected, but also then stimulating an immune response in the other tumors. That was a phase 1, so we now have early results from that the company is sufficiently interested in to consider further, we hope, and we'll wait to hear from them. There's also another intra-liver approach called PERIO-1, which is showing good results at an early stage. And then also a PRAME-directed IMTAC, which is like the Tebentafusp, but just at a different antigen. So hopefully from all of this, we will get finally an adjuvant treatment for uveal melanoma, and we'll get more options for treatment when it has developed. I would just end to say one of the key things with a rare disease like uveal melanoma is collecting as much information as we can on people with the disease. So not only trials, but real-world data. And this can provide complementary evidence to the trial. So if you've got a trial which you only managed to recruit 20 patients on, if you then have 200 patients with a similar kind of status at the beginning, you can then compare and see whether the treatment that you looked at is really worth, that is by chance, or whether it looks like it's actually a real signal. But you can also look at questions that are impossible to look at in trials or not realistic. So if you're looking at small subgroups or sequencing between things where it becomes just really not feasible to do it, this can make a huge difference. And we have been involved in setting up an international registry with the US, Australia, and ourselves, which is currently open in Liverpool, also in the US and Australia. And we've got set up at Sheffield and Mount Vernon. But like a lot of these things, it takes quite a while. And there's also a patient-directed registry led by the CureOM in the US, which I've put the link on there. So I only remain to say thank you very much for your attention, and of course to Melanoma Focus for all their support in this effort, which I think is really important, and specifically to Nancy Turnbull, who was the project manager for these and did an outstanding job. Thank you.